Hello and welcome to another critical care session. This will be one of several on trauma. This one is focused on the resuscitation phase as well as pediatric differences in abdominal injuries. Usual disclaimer, no conflicts of interest, and this is information that is collected by myself, and that there may be some differences from what you've previously learned. Checklist of what to do. Look at our MTP boxes or find out from someone else what's exactly in them, as well as how to dose TXA. If you're at Wisconsin currently, there'll be upcoming lectures about the MATIC trial that we are enrolled in. Familiarize yourself with the trauma bay and where the equipment is in there, and see if you can meet the trauma program manager. The topics we'll be covering today: hemostatic and damage control resuscitation, differences in indications for pediatric trauma thoracotomy, aka the clamshell, and then some differences in assessment and treatment of abdominal injuries in children compared to how those are treated in adults. So what are the principles of damage control resuscitation or hemostatic resuscitation? Rapid control of bleeding as soon as possible. Time to control of bleeding has been shown to correlate to outcomes. Avoidance of the causes of coagulopathy, hemodilution, acidosis, hypocalcemia, the disadvantages of crystalloid resuscitation, balanced transfusion, or even better if whole blood is available, which we'll be talking about in the upcoming slides. Hemostatic adjuncts, including antifibrinolytics, usually TXA, tourniquets. We'll be talking about whether or not viscoelastic tests like TEGs or ROTEMs are useful. And we'll talk about a movement over the last decade or so towards circulation-first resuscitation, especially in those patients that are presenting in hemorrhagic shock. We'll start by going through recommendations from the 2023 Pediatric Trauma Hemorrhagic Shock Consensus Conference. So the first recommendation can be summed up with a quote that was from one of the giants in trauma, Tom Scalea, who told me, "If it doesn't clot or carry oxygen, why give it?" In response to why give crystalloids in the trauma bay. So their recommendation was that in traumatically injured children in hemorrhagic shock, the use of blood products should be prioritized over the use of crystalloids for resuscitation. And several studies, which I've cited here, show that overuse of crystalloids can result in dilutional coagulopathy and interstitial edema, and poor outcomes, including more days on the ventilator and lower survival. There seems to be some advantages to whole blood, especially from our adult literature. Transfusion of low titer group O whole blood instead of individual products has coagulation and logistical advantages and has been associated with fewer days on the ventilator, faster resolution of shock, lower transfusion overall volume, as well as decreased mortality. And so the MATIC-2 trial is kicking off, which is a study of this whole blood in children, which we'll talk about on the next slide, and then you'll have separate informational slides as well if you're listening from Milwaukee, since we are enrolled in this study. If you do not have whole blood available, individual components should be transfused in a 1:1:1 ratio of red cells to plasma to platelets. Although if your platelets are stored as what we formerly called as the six-pack, you may be transfusing not 1:1:1 units, but 6, and then before you get to your first unit of platelets. The 1:1:1 ratio improves the trauma endotheliopathy, which is a relatively new research topic, platelet dysfunction, coagulopathy, and improves survival. The MATIC-2 trial, which we are enrolled in, so MATIC-1, or just MATIC, massive transfusion in children, looking at balanced transfusion ratios. Now MATIC-2, looking at whole blood transfusion. So we are enrolling children, which are defined as less than or equal to 18 years of age, for whom a massive transfusion protocol, MTP, has been activated with confirmed or suspected life-threatening hemorrhage, they defined as 2 of the following: hypotension, tachycardia, and traumatic injury consistent with bleeding. So centers in this study will be randomized to one of 4 groups based on their transfusing of whole blood plus or minus TXA and component therapy plus or minus TXA. Of the groups that are giving whole blood, up to 8 units can be given. Recommendation 2 is a straightforward, fast one. If pre-hospital transfusion is available, then it should be considered. It is currently not in Milwaukee, although there is some movement towards doing that. Recommendation 3 was for adjuncts, hemostatic adjuncts. And so they concluded that the empiric use of TXA can be considered in traumatically injured children presenting within 3 hours of their injury. If they're presenting later than that, then it is not indicated, and that's based on adult data, which is good data. The typical dosing unit for children is a 15 milligram per kilogram up to 1 gram infusion over the first 10 minutes, followed by 2 milligrams per kilogram per hour over the next 8 hours. They did recommend TXA over aminocaproic acid. There was insufficient data for them to recommend PSCC, as well as the use of TEG or ROTAM or viscoelastic monitoring to guide antifibrinolytic therapy specifically, although it can be used or recommended to be used for component transfusion. There was insufficient data that empiric use of cryoprecipitate or fibrinogen improves outcomes, although in patients who have depleted of those factors should have those transfused. Recommendation 4 was in favor of the use of tourniquets. Now this is an important difference regarding permissive hypotension, which is not used and not recommended to be used for children. And the reasons is threefold. One, that permissive hypotension is still somewhat controversial in adults, although some newer papers are still in favor of it. However, children's ability to compensate in hemorrhagic shock, they may not be demonstrating hypotension until they've lost approximately half their blood, and at which point they are at a much more deranged state physiologically, with reduced ability to compensate for further blood loss. Pediatric hemorrhagic shock is often accompanied by TBI, for which hypotension is obviously bad. Summary of this is that this is not a strategy that is appropriate in children. Recommendation 6 was for initial resuscitation with a massive transfusion protocol and a balanced blood product administration, followed by a goal-directed resuscitation after that, and recommending for the use of viscoelastic monitoring like TEG or ROTAM when available to guide the further blood product administration, but not the use of antifibrinolytics. Over the last decade and a half or so, there's been a movement towards circulation-first resuscitation strategies for trauma, especially patients who are presenting in hemorrhagic shock. And the reason for that is that although definitive airway management is needed for many severely injured patients, focusing on airway and endotracheal intubation before appropriate resuscitation in patients in extremis may result in further hypotension and precipitate cardiac arrest. There's been a number of publications on this topic in both adults and children, the adults ones particularly by Paula Ferrata at ANOVA, arguing for a change in approach to prioritize circulation first. At major trauma centers, this is already happening due to the advanced resource capabilities to simultaneously address everything at the same time. However, in other areas, including more limited resources at our children's hospital, this is an important thing to know. In January of 2024, there was an article in the Journal of American College of Surgeons called Prioritizing Circulation to Improve Outcomes for Patients with Extenuating Injury, which was a literature review of this circulation first strategy. The last author was a giant in trauma surgery, David Feliciano, who actually died that same month. He was a good friend of mine. But that paper concluded that in reviewing both the adult and pediatric trauma literature, the evidence supports that early intubation, especially in patients with TBI, does not improve outcomes, especially pre-hospital intubation, and may worsen morbidity and mortality, whereas a circulation-first strategy can improve outcomes. Patients in hemorrhagic shock can usually have their airway maintained with basic airway maneuvers, face mac, bag mal, vasc ventilation, the use of adjunct airways, with intubation performed in the operating room just prior to operation, with obvious exceptions for patients who are actively vomiting or highly agitated or have severe facial trauma burns, significant TBI, or requiring earlier intubation. The drug selection should prioritize medications which have lesser effect on hemodynamics, such as ketamine and etomidate. And so this was their figure, of which they concluded that so if the patient has non-compressible exsanguinating hemorrhage, consider delaying intubation until control of bleeding is imminent. Another key difference between adults and trauma is that the indications for ED thoracotomy or clamshell are stricter in children. The table here is from a practice management guideline that was released in 2023 as a collaboration between the Pediatric Trauma Society East and West. And so basically, if children present with signs of life in traumatic arrest, then there is a conditional recommendation in support of trauma thoracotomy, and those without signs of life, conditional recommendation against, which is different from adults, in which particularly penetrating trauma or blunt trauma presenting within a certain time window, there is still a more favorable outcome as possible, likely due to the fact that when children are in arrest, their reserve has just been totally depleted due to their higher ability to compensate, and they are in a more deranged physiology. What are signs of life? Cardiac electrical activity, respiratory effort, pupillary response, palpable pulses, measurable blood pressure, extremity movement. The most common of those would be cardiac electrical activity for a patient presenting in PEA of trauma arrest. They also recommended to consider the use of ultrasound and thoracostomies prior to performing a thoracotomy. Summary of the resuscitation part of this talk. So the leading cause of hypotension in trauma is hemorrhage. There are, of course, other causes, pneumothorax, hemothorax, etc. But the number one reason is blood loss. Children require a greater percent blood loss than adults in order to cause hypotension, often not until 45-50% blood loss will hypotension be present in children. The unique ability of children to compensate for hemorrhage via catecholamine response, etc., maintaining their blood pressure, leads to key difference from adults, which is that children in hemorrhagic shock, particularly hypotensive and severely hypotensive children, are in a particularly fragile state. And so this has led to several differences in their treatment. We do not do permissive hypotension in children, like is allowed for in adult resuscitation. We have stricter indications for resuscitative thoracotomy. Signs of life should be present in the trauma bay in order to have an indication for resuscitative thoracotomy. The easiest one out of all the different ones, in my opinion, is the cardiac electrical activity. It's one of the last ones to be lost, and it's unlike looking in their eyes and seeing if anybody has a flashlight or trying to listen for sounds or anything like that. Or it's most obviously present. There's an increased importance, in my opinion, of a circulation first resuscitation strategy for the hypotensive child, because intubation, especially drug-assisted intubations in that setting, can be particularly treacherous because of how tenuously they are hanging on by a thread, and removal of their ability to compensate for that hemorrhage shock could precipitate cardiac arrest, which we know from the resuscitative thoracotomy data has poor outcomes in children once they've reached that state. Therefore, for the exsanguinating child, the priority in the ED is to obtain IV or IO access on an uninjured venous path. If they're shot in the shoulder, you don't use the arm. If they're shot in the belly, try to avoid the groins and legs, because you could be transfusing the blood into the void or into the retroperitoneum. And then after obtaining that access, to rapidly transfuse blood. Peripheral IV access can sometimes be challenging as the veins are relatively flat. My preference in that case is to have IOs placed. Central venous access is an option, but it's usually slower than getting IOs and has its own problems, including sterility, although that's less of a concern in the setting of exsanguinating hemorrhage. People that are shot in the chest and belly, usually the femoral veins are distal to that injury if you're concerned about an injury to the caval or iliac veins. There is limited room at the chest and head to place subclavian and IJ lines. Both of those have a potential complication of pneumothorax, For someone who's fragilely hanging on to their blood pressure, that could potentially be catastrophic. You don't need to get lab draw, that's not a priority. Get the access, get the blood in, and then get to where you can be in a position for definitive hemorrhage control. And then the last thing I hear is an awake patient, if they're saying, I can't breathe, that can sometimes be a presentation of the end stages of hemorrhagic shock. As they're not getting oxygen delivery, they feel like they can't take a breath, and that can prompt desire for intubation or chest tube placement, etc. And if their reason for that presentation is actually from hemorrhage, either of those two things could also be fatal. So just consider that on the differential. Now we're going to be talking about some abdominal injuries and how those are different from how those are differently assessed and treated compared to how you may have been managing those injuries in your adult general surgery residency. General differences in the specific organs: diaphragm, liver, spleen, kidney, pancreas, bladder, bowel. So in general assessment differences, usefulness of the FAST is almost entirely useless in pediatrics. Small amounts of fluid can be normal, and even if there is fluid present, the majority of solid organ injuries, even high-grade injuries, are managed non-operatively. There's a very small population, such as those for whom thoracotomy might be recommended in the ED, for whom the FAST might be useful. General assessment, moving on, the seatbelt sign. Although there is newer adult evidence that adult patients with a normal CT scan who have a seatbelt sign may be safely discharged, the general consensus, although there are no evidence behind this yet, is that pediatric patients in these circumstances should still undergo observation for looking for delayed injury. Due to their increased incidence of perceived incidence of injuries in this setting, as well as their reduced capacity to describe how they're feeling. There are stricter criteria for CT scans in children for both head, chest, abdomen. We'll talk about some of those for the abdomen on the next slide. And then the vast majority of blood solid organ injuries, even high grade, can be managed non-operatively. And we'll talk about indications for empiric ICU or bed rest. When to CT scan? So a number of publications which are cited here determining what combination of things can reduce the use of radiation in children. And so we are currently using a combination of physical exam with some transaminases, liver enzymes, pancreatic enzymes, and using those to assess and exclude the need for abdominal CT scan. Some of these will be institutionally variable. For example, this study, the AST greater than 200 would predict the need, would follow then with a CT scan. However, some are using a higher level, 400. And that'll just depend on which institution you're practicing it and which of the most recent guidelines there have chosen to incorporate. But in general, a patient with normal liver enzymes, a normal physical exam of the abdomen, and a normal chest X-ray and normal pancreatic enzymes is excluded from the need for a CT scan. We'll talk about indications for chest, head, or spine in separate trauma sessions. Diaphragm injuries, diagnosed and managed largely similar to how you're practicing in adults. And again, similar to those, the diagnosis is often delayed. Moving on to the liver. The same imaging criteria used to categorize those liver injuries into grades 1 to 5. The differences are in management regarding the need for admission, need for bed rest, angiography, operation, or aftercare. So low-grade solid organ injuries, liver, kidney, may be safely discharged from the ED, depending on if your institution will allow that. And then we have some updated 2023 guidelines that were presented to ABSA regarding blood, liver, and spleen injuries. And those became a much more liberal strategy with reduced ICU admissions, reduced activity restrictions, reduced diet restrictions, and following more clinical status of the patient and basing tests or admissions based on those rather than the grade of the injury itself. Unlike in adults, contrast plus or active extravasation from these injuries in children does not indicate a prophylactic angioembolization. Both angioembolization and operation are based on stability in response to transfusion, and only uncommonly needed. Options for management of blunt and penetrating liver injuries are similar to adults: PAC, Pringle, Prey, angioembolization, spaghetti balloons, hepatography. Depending on where you're practicing, you may or may not have access to some of these endovascular techniques, but the management is largely similar. Complications, again, similar to those seen in adults. Bile leak up at rates of 25% in high-grade injuries. Pseudoaneurysm, hemophilia can all be seen. Although we don't generally perform follow-up imaging tests for those, unless they present with symptoms. Moving on to the spleen. Again, similar to the liver, there's similar imaging criteria for grading these injuries. The difference is, again, following those same EMSA guidelines for liver and spleen are in the need for admission for bed rest for angiography, as well as aftercare with more indications for antibiotics and for potentially longer antibiotics and for vaccination as well. Like low-grade liver injuries, low-grade splenic injuries may be safely discharged from the ED. And the same figure here is shown for the liver as for the spleen as for the liver on the previous slides. So regarding antibiotics and vaccination, there's no great data to support how long these should be given for, or specifically for antibiotics. Neither is indicated after angioembolization alone. Post-splenectomy, the vaccines similar to adults should be given before discharge. Antibiotics, there are varying recommendations. One Trauma Society consensus guideline was for antibiotics either until age 5 or for 1 year post-splenectomy from the AAP, although there are some other recommendations to do it for longer until those patients are adults. That's to prevent overwhelming post-splenectomy sepsis. Moving on to the kidneys, again, similar or the same imaging criteria for grading those injuries. Again, low-grade renal injuries may be safely discharged from the emergency department. For the stable patient, no bed rest necessary. Hematuria is not generally useful or for management decisions or prompting repeat imaging and may persist for weeks after the injury. In those who are unresponsive to transfusion or patients with ongoing bleeding, favor angioembolization. Greater than 95% of blunt kidney injuries can be managed non-operatively. They do need follow-up for blood pressure monitoring as they may develop hypertension post-injury. Moving on to the pancreas. Again, the same imaging criteria used to grade these injuries. Differences are indications for surgery or endoscopy, and what exactly to do with these injuries is somewhat controversial, and due to their uncommon incidence, there is not great data. So the figure on the right is from the Pediatric Trauma Society and largely advocates for non-operative management of most injuries, arguing that the majority of the injuries do heal. They do recommend performing axial imaging or ERCP as needed to assess the duct. And so injuries without ductal disruption, there is general consensus for non-operative management, but injuries involving the duct, it's unclear. Again, the PTS favors the non-operative management for those. Most of those, and it's true that most of those do heal, but the process can be months long, and if those patients are NPO for 6 months, to ask that of a child can be difficult. If these patients are presenting, and often the mechanism is a handlebar injury, or I've seen from a 2-year-old who a daycare table fell on, or as well as non-accidental trauma from these children being punched. If they present within 72 hours of their injury, the surgery is much easier. After that, the inflammation is significant and the surgery is more difficult, usually distal pancreatectomy due to the location of where the pancreatic laceration is. So if you can do that surgery earlier, they have less time in the hospital, more time to restore a diet, and their recovery is much quicker. It's true that the majority of them can heal without operation, but the duration of illness can be significantly prolonged. And so for patients presenting relatively early from their injury with evidence of ductal disruption, I am currently in the camp of performing an earlier distal pancreatectomy. We'll see as we get more evidence which way that falls. Moving on to the hollow viscouses in the belly. So the bladder, the only difference really in terms of assessment management is that in children, a full bladder can reach much higher than in adults and places it more at risk for blunt or penetrating trauma. Besides being aware of that, the management and imaging guidelines are largely similar to those of adults. Blunt intestinal injury can be difficult to diagnose, similar to adults. However, unlike adults where delay in diagnosis of intestinal injury is associated with worse outcomes, we have a paper from Journal of Pediatric Surgery in 2010 that delay even past 24 hours does not change outcomes. And so that's permitted more liberal use of observation strategies rather than repeat imaging and exposure to repeated doses of radiation. They are different injury patterns, but otherwise care is similar. The duodenum or pancreas or seatbelt injuries due to improper location of the seatbelt wearing in children. If they're not in a booster seat, it's more common in children than in adults, but the management is otherwise similar. All right, moving on to some questions. Teenager comes in with 2 gunshot wounds on either side of the lower abdomen. He is hypotensive, tachycardic, and is awake, saying, "I can't breathe, I can't breathe." Next best step in resuscitation is to perform immediate drug-assisted intubation, obtain IV access or IO access, and start transfusions, perform a chest X-ray or a fast X-ray. Well, so you haven't moved on to your adjuncts to the survey yet, so you're basically between doing an ABC approach and saying he can't breathe. Let's just say in the question that you don't have any suspicion for airway injury, and so the correct answer would be to start a circulation first resuscitation strategy. And often, young adults, pediatric patients, this phrase, "I can't breathe," is when they are at the very last bit of their hemorrhagic shock state, peri-arrest. And it's not actually an airway issue, it's a need for immediate blood transfusion. That being said, if you have suspicions to that there is an injury that could cause a pneumothorax or some other cause of that, then that should definitely be evaluated. But in this patient, with the only 2 wounds being in the low abdomen, he needs blood. All right, a 10-year-old female fell off a tree swing and has a grade 5 splenic injury with active contractive extravasation. However, she is hemodynamically normal and no other signs of injury. She should be taken to the operating room for splenectomy, undergo angioembolization, be admitted to the ICU, or just taken to the floor. And our most recent guidelines say that this is the safest, not the safest, a number of these are safe. PICU is safe too. This is the most appropriate use of resources for this patient, I should say. All right, a 7-year-old female fell off a horse, landing on her back. She has grade 2 kidney injury with hematuria and is hemodynamically normal. No other injuries. The most appropriate disposition would be home, floor, ICU, or OR. So low-grade blunt solid organ injuries may be safely managed as an outpatient. That's it. I've included some recommended reading for you. This is overall a little shorter of a session. We'll have some additional ones on neurotrauma as well as chest vascular injuries. See you later.